So welcome. Thank you all for coming. I'm going to do a very quick introduction to Alison Leary, Professor Alison Leary, sorry. So I've had the pleasure of knowing Alison for probably about 12 years. I don't know exactly, but Alison's contribution to healthcare research has been pretty incredible, really. And over recent times, I keep hearing Alison on the radio, on the television, being interviewed, because she really is a subject matter expert in this field. Okay, so we've got a great presenter today, really interesting subject matter. Now, Alison's bio is pretty impressive as well. She's a senior consultant at the World Health Organization's Human Research for Health. She is also the chair of healthcare and workforce modelling at London's South Bank University, where she undertakes a range of projects around modelling complex systems in healthcare. Okay, so her interests are very much complexity in healthcare, mathematical models, and data science. And Alison is also a registered nurse on top of all that, and she's particularly interested in specialist and advanced practice. So, without further ado, I'm going to hand over to Professor Alison Leary. Oh, sorry, wrong way.
Nearly had a near miss then. Thank you. Do you want your laptop back?
Oh yeah, it was precarious.
There you go.
Balance
Yeah,
on the sides.
we'll have an actual harm then. So thank you very much for inviting me to talk today about data integration. I'm quite surprised there's so many people in the room, because usually not that many people are interested in this. It's not a very technical talk, but if you would like to go into the more technical aspects of data integration, I'm really happy to do that. So I've been working for quite a long time integrating different data sets in the NHS. Around particularly incidents and safety. So I'm going to talk a little bit about that today. I'm going to start with why that's done in other industries. So in the NHS, that's not a routinely done thing. But in many other industries that we work with, for example, the aviation industry, the nuclear industry, oil and gas, what we'd call high reliability organisations integrate this data routinely all the time. So what I'm going to do is show you a few examples of how we've really use that in terms of its potential. So high reliability safety critical organisations are organisations where catastrophe could occur at any time, but they somehow manage to avoid it. And one of the reasons that Kathleen Sutcliffe and Carl Weick, who did the original work, said this was called sensitivity to operations. So they collect data that is very sensitive to their mission and very sensitive to the outcomes that they want. Now, in healthcare, we collect a lot of data, but not all of it is sensitive to the mission, whatever you think the mission is. You tell I worked at NASA, right? Because everything's a mission there. And also in terms of outcomes. So a lot of data that we collect in healthcare is performance data. But we do collect a lot of workforce data, and we do collect a lot of incident reporting data. And there's quite a lot of potential in that. The other thing they have is something called deference to expertise. So this is where safety and incident reporting data really overlaps with workforce data. So I'm quite often told we have more and more people working in the NHS, but why is productivity going down? We are actually losing what we would call proficiency, and I'm going to talk about that a little bit. So if we look at safety and how high reliability safety critical organisations use this data, they use it to square which Eric Holnagel calls this circle, which he puts in a square for some reason. So there is a tension always between efficiency, productivity, quality and safety. And what most safety critical organisations do is they retain a proficient workforce. So they will retain a workforce that manages risk. And in the NHS, we've lost a lot of proficient workers. So proficient workers are people that are not experts, but do a really good job every day and are very experienced people. So that's sort of what I'm going to talk a little bit about. And then we've got incident reporting itself. Now, incident reporting itself is done very differently in the other industries. So what we have generally in the NHS is a reliance on a sort of linear approach, which focuses on things like root cause analysis. Very rarely in a complex system does one incident have one root cause. So I'm going to explore a little bit about that as well. So you open an incident, you investigate the incident, you close the incident. And then what happens to the learning from that? Does it just stay with that incident? In other industries, that would be a cumulative thing and it would be overlapped with other data. So what we would get in most other industries is insight generated by overlapping different sorts of data. Now in healthcare, and particularly in NHS data, and particularly in the way it's organised, in its architecture, it's kind of difficult to do that. Currently, people like me, or more accurately, the research fellows that I've got that are really much cleverer than me now, go around extracting data, integrating data, and then telling people what we found. Now, that means we're always working in the past. So we can tell you what went wrong 6 months ago, but we can't necessarily tell you what's going on now. So that is a lower sensitivity to operations. In other safety critical industries like the airline industry, I'd be able to go and log on and look at that right now. And actually, I'd even be able to do that in retail grocery. So these are some of the things that are kind of challenges. So when we integrate these sets of data, what is it we find? And I've got some examples of work that we've done that can show you this. But there's I think more of an interest in this now. So I think we're going to see more evidence of this coming out. So one of the first ones we did quite a long time ago was in the acute sector, looked at acute inpatient care. We wanted to understand the relationship with registered nurses, experienced registered nurses, and we chose slips, trips and falls. We worked with a trust that had quite a lot of issues with slips, trips and falls. Now, what you can see is this sort of what we call a sigmoid curve. So generally, when we map this out, we did this about 8 or 9 years ago, but we find this every time. If you add experienced people here, then you'll get to a sweet spot where the thing you don't want to happen stops happening. Adding more people makes no difference. And that's a kind of repeating thing that we see. So you see this with slips, trips and falls, and it ends up being something that is a repeating pattern. And it doesn't matter what the thing being reported is, we constantly find this pattern, this sigmoid function. So, and when you look at this, what you can see is things like when stuff happens and who was there. And it kind of seems really kind of fundamental, right? But actually, very few people actually do this. But you probably have that data. You could probably bring these two data sets together. And we've done this many, many times. We looked at it lots of times in different organisations in the UK and in other countries. And we find the same sort of thing most of the time. And also, the literature mostly bears this out as well when you look at particularly the nursing workforce, because the nursing workforce is the most over-investigated workforce, I think, in the entire world. When you look at, if you look at safe staffing on Google Scholar, 1.7 million papers come up. I couldn't attest to the rigour of all of them, but it is a very over-investigated workforce. Thankfully, people don't investigate mathematicians to that degree, otherwise I'd probably lose my job. But what we also find is this sort of pattern. So we find that when you're adding proficient workers, now this kind of upsets people at first, reporting goes up. Incident reporting goes up the more people you add, the more experienced proficient workers there are. And we started to wonder why this was. So we started to work with people like ethnographers to try and find out why this was. And then when you add enough, whatever that is, people, reporting goes down. So, and you particularly see no harm, low harm, near miss reporting go up, which is really interesting. So we think there's like a cultural thing there, and some other people have researched that and looked at the culture of incident reporting and their relationship with workforce. So we also think about this in terms of introducing new workers. So we did an evaluation for NHS England. They realised people were getting sick in hospital who had diabetes. and they were staying longer in hospital, and some of them were dying. I didn't realise it at the time, but I think insulin was something like the third most dangerous drug. So NHS England a few years ago decided they were going to introduce two groups of workers. One was the diabetes inpatient specialist nurse, that's the DISN, and the other was podiatrists in the community. And they asked us to evaluate the DISN role. The DISN role wasn't an advanced practice role. We usually work with people with advanced practice, but it was a specialist nursing role that was an enhanced, probably more an enhanced practice role, but they would go around making sure all the diabetes care was given. And we found some really interesting things. So a lot of people have diabetes in hospital. We kind of knew that already. But what we found was that introducing these small, like, proactive workers was actually decreasing the length of stay, and it would decrease rates of readmission. It had like good clinical outcomes. But the really interesting thing about this was that in diabetes there is a national data set, particularly for adverse outcomes. And we started to look at that, and we were working in some trusts that had very poor diabetes outcomes. And we found they had very low rates of incident reporting. And then when you go into that a little bit deeper, so we did the maths. It's great. These people are great. They're cost effective. You know, you should have more of them, or enough of them, whatever that is. But we really wanted to know why people weren't reporting. And I'll let you guess why people weren't reporting incidents, because you probably know already, right? So we also looked at this in inpatient mental health. So a really, really innovative trust, actually. It's quite interesting sort of who asks you to do this and who probably wouldn't want you to do this. A lot of organisations are actually quite welcoming, and they actually want to scrutinise their own data, which is really good. But inpatient mental health was an interesting one, because we didn't look at, it was following a guy called Sidney Decker, who's a safety scientist. And we looked at safety. Now, in other safety critical high reliability organisations, we wouldn't look at customer safety, we would look at safety. There is no distinction between patient safety and other people's safety. It is just about safety. And what we found there was some interesting relationships around harm to not only patients but also to staff. So essentially, better staffing, more proficient staffing, led to lower incidents, and actually some quite serious incidents as well. So once you start overlapping workforce data with incident data, you can get some really interesting things coming out, but you can also get the insight that you need to make decisions, particularly in terms of productivity. You're very welcome to have all these slides, actually. That's not an issue at all. And all these papers have been published, so... So it's not just, and what we also found with this is one of the issues where we talk about proficient workforce, not just numbers. We also found that, and we've done this in other areas like cancer, where you have more experienced and qualified people, also people with postgraduate qualifications, and patients have more exposure to those people, you see less harm to the staff and the patients. So it's a really nice area where you can look at these data sets overlapping. So the next slide is really, really busy, I've realised. So this is a study this is the final slide that I'm going to have with loads of data on, is my colleague Sarah Jane Jones at Staffordshire University. They're just about to publish this, and they wanted to see if they could predict when people were leaving. So we've looked at why people, we published a paper a couple of weeks ago about why people leave. They don't just leave for one reason, they leave for many reasons. But this is what increases turnover against time. So some surprising things. If you want to reduce turnover, hire ward clerks. Ward clerks have a really big impact on people turning over. So these are associations at this point because they need to be dived into. But what we also see is lower turnover in places where people report incidents, both low harm, near miss, and even higher harm incidents. So if people feel confident to report incidents, there is lower turnover. And we found all these different factors and when people are likely to leave that increase or decrease turnover. So I thought you might find that quite interesting. We'll hopefully publish that early next year. So this kind of data is really useful in terms of integration and insight. So some of the things that we would use in other safety critical industries, we'd use sickness data, for example. Do you know where people are absent? If you're seeing places that are hotspots for absenteeism or sickness, that's a place where you kind of go and look at the incident data as well, or if it's not being reported. So that's a key one. We would look at turnover. So all of this alongside your incident data can give you some real insights in terms of safety and creating a safety culture. We've got no or near harm reporting, and is it very low? Because it is high risk work, so healthcare is high risk work, health and social care, high risk work. You should have a background all the time of no and low harm reporting. If you don't have that, that is probably a red flag. And in fact, I work as an expert witness occasionally, and what I always ask is can you request the instant reporting? And invariably, there isn't any. So for me, it's a bit of a red flag. The types of rostered staff are really important, so you need to look beyond the head count. That is really important. Workforce safety and safe staffing is much more than numbers, very much more than numbers. I think that there's this whole thing about one of the other red flags that we would look for. So when we mine text in incident reporting, obviously we're familiar with RLDatix, but other incident reporting systems are available, I should say. But what we find is things like profanity coming up. So profanity is a bit of a red flag in terms of your culture, and people RLDatixing each other. So where you've got people, what we call it RLDatix, seems like a verb now, but where you've got people reporting each other, I've worked with organisations that say, well, that's just people disagreeing and that's petty. Other safety critical industries would take that really, really seriously. I worked in a big nuclear installation, and the guy said, well, you know, a big incident could start over an argument over a car park space. These things escalate, and it's much better to have someone that does mediation where you see this happening in terms of your workforce's well-being, and it will help with retention. And the absence of reporting we would see as a red flag generally in these data sets. So there are all these cultural aspects to incident reporting. So it's great to look at the data and it's great to integrate the data, but you have to contextualise this data as well, I think. So these are just some of the thoughts that I've been really thinking about. So is patient safety as a concept outdated? We wouldn't have it in any other industry. Is that giving us the focus in the wrong place? Are we looking at patient incidents and staff incidents and then workforce over here? All of these things really should come together to give intelligence about the state of your system, because you operate in a big, complex system. There is quite often the temptation, I find, particularly in healthcare organisations, to try and oversimplify the things that are actually very, very complex. And we see that a lot with flow, actually. So I think these are just some of the thoughts that sort of occurred to me. So you're very welcome to have these slides. And for me, I think the take-home for this is that the key issue about a productive workforce is that a workforce is made up of people. So I'm a mathematician primarily, but workforce is a social science, and so is safety. They are social sciences. How are you using the data you currently have, and how are you integrating the data you currently have to gain more insight into the situation that people are facing and what they're experiencing at work? And also to think about where your big areas of risk are, because there are lots of quite big areas of risk at the moment. So that's it from me. That's a quick tour of data integration. And I'd be really happy to answer any questions.